It starts at night. The sheet touches your toes and it burns. Your socks feel like sandpaper. Put your hand on them and the skin tells you nothing. Ordinary, unremarkable, sometimes cool. The fire is on the inside where your hand cannot reach it. And nobody explains the rest. The burning is unbearable, yet you can cross gravel and never feel it. Exquisite pain and dead numbness. Same foot, same moment. I am an interventional pain physician in St. Louis, and that is not a contradiction. It is a signature. What most people with these feet get is a prescription and a shrug. Gabapentin at 300 milligrams, then 900, then 1800, and when it fails, more. Nobody checks your B12 or your thyroid. Nobody sends a serum protein electrophoresis with immunofixation to look for a monoclonal gammopathy. And electrophoresis alone is not enough because the small clones hide from it. That neuropathy looks identical from across the room and belongs in a different clinic. Nobody asks honestly about alcohol or examines your lumbar spine for a compressed root. And when gabapentin fails, the answer is too often an opioid, which the 2022 American Academy of Neurology guideline, by Price and colleagues in neurology, specifically recommends against here. In that same 15 minutes, nobody takes your shoes off. That is the failure that costs limbs. Look at the length of the wire, because the length is the whole disease. Diabetic peripheral neuropathy is a length-dependent, dying-back axonopathy. It fails at the far end first. The longest axons in your body belong to sensory cells whose bodies sit in the ganglia just outside your lumbar spine and whose fibers run all the way to your great toe, nearly a meter of membrane that one cell must supply, maintain, and power from a distance. When the numbness climbs to about your knees, your fingertips are next in line, because that is the point where the remaining leg axon and the axon running to your fingertip are the same length. That is when the hands begin and the pattern becomes stocking and glove. Small fibers, the unmyelinated C fibers, and the thinly myelinated A delta fibers that carry burning, temperature, and pinprick degenerate first. That is the burning and the allodynia, a bedsheet read as an injury. Large myelinated fibers fail later. Numbness, lost vibration and joint position sense, unsteadiness in the dark. In preclinical models, hyperglycemia and abnormal lipids drive polyol flux, glycation end products, oxidative stress, and injury to the vasa nervorum, the small vessels feeding the nerve, work that remains preclinical and has produced no approved disease-modifying therapy. Pain persisting after glucose control we attribute to central sensitization, a reasonable inference, not a measured fact. You have been told that getting your sugar down resolves this. The Cochrane Review by Callahan and colleagues, published in 2012 and never updated, found enhanced glucose control prevents new neuropathy in type 1 diabetes on high-quality evidence. In type 2, the reduction did not reach statistical significance, and that evidence is about preventing neuropathy, not reversing damage you already have. The same review found intensive lowering significantly increases severe hypoglycemia. Glucose control is still the only intervention with any disease modifying evidence behind it, and it is worth pursuing, but pursue to a target your diabetes physician sets for you, not to the lowest number you can force. Intensive lowering has its own body count in severe hypoglycemia. You deserve to know what glucose control buys you and what it does not. So take your shoes off, because that is where this starts here. Nothing gets injected into your spine and nothing gets implanted until the stocking pattern on your own feet has been mapped by hand and the 5 things that imitate it have been ruled out on paper. Confirmed diabetes, a length-dependent, symmetric distribution on examination, monofilament, tuning fork, pinprick, ankle reflexes, proprioception. Electrodiagnostic testing where it changes the answer, though nerve conduction studies read large fibers and can be normal in a pure small fiber neuropathy. When the exam says small fiber and the conduction study says normal, a 3 millimeter skin punch biopsy from the distal leg settles it by counting the nerve fibers in your own epidermis. The mimics, B12 deficiency, thyroid disease, monoclonal gammopathy, alcohol, lumbosacral radiculopathy. A foot that cannot feel a pebble will not report an ulcer until it is deep, so feet get inspected every visit. Daily inspection is how you keep your leg. The 2022 guideline offers 4 classes: tricyclic antidepressants, serotonin, norepinephrine reuptake inhibitors, gabapentinoids, and sodium channel blockers. Tricyclics showed the largest effect size at low confidence, which I say out loud. These drugs are symptomatic. The benefit lasts only while you take them. Only pregabalin, duloxetine, tapentadol extended release, and the 8% capsaicin patch are FDA approved for this indication. And I will say the uncomfortable part out loud. Tapentadol is an opioid. It carries an FDA approval here and a level B recommendation against it from that same 2022 guideline. I do not reach for it, and if someone offers it to you, ask them why the guideline disagrees. Gabapentin, amitriptyline, nortriptyline, venlafaxine, and the sodium channel blockers are off-label, legitimate, evidence-informed, and off-label. You should be told which is which. Gabapentinoids need renal dose reduction and cause sedation, ankle swelling, weight gain, and falls with serious respiratory risk alongside sedatives. Tricyclics carry cardiac conduction effects, so cardiac history and an ECG come first, plus anticholinergic effects and orthostatic drops. Antidepressants and anti-seizure drugs carry suicidality warnings. When pain stays severe after a gabapentinoid plus one other class for a year or longer, we discuss high-frequency spinal cord stimulation. Under live fluoroscopy, 2 8-contact percutaneous leads are placed through an interlaminar approach into the posterior epidural space, spanning the 8th through 11th thoracic vertebral bodies over the dorsal columns that carry sensation from your feet and legs. You do a 1-week trial first with the leads externalized through the skin. If it does not deliver, nothing is implanted and the leads come out. In Peterson and colleagues' randomized trial in JAMA Neurology in 2021, 79% on 10 kilohertz stimulation plus conventional management reached at least 50% relief without worsening of neurological deficits at 3 months versus 5% on conventional management alone. It was open label, not sham controlled, and the control arm crossed over at 6 months, so anything past that is uncontrolled. Enrollment required an HbA1c of 10 or less, a BMI of 45 or less, pain of 5 out of 10 or worse, and no active foot ulcer. The FDA approval here is device-specific, not a class approval. The risks are real. Infection requiring device removal, about 2% in that trial. Likelier with diabetes, lead migration, epidural hematoma, dural puncture, hardware failure, and loss of effect over time. Ketogenic nutrition, specialized pro-resolving mediators, and photobiomodulation are adjunctive, off-label, and unproven here. If you want to try one, I will say plainly that it is unproven for your nerves. We will set a fixed trial window and a stopping rule before you start, and we will stop if nothing changes. That is an optional adjunct with a deadline. It is not treatment for your neuropathy, and I will not sell it to you as one. What I am about to describe is a composite, a picture assembled from many patients with this condition, not one person's chart. Years of burning feet. Gabapentin pushed to the ceiling, then duloxetine, then a tricyclic stopped early when the ECG showed a conduction delay, months with the primary team to get an HbA1c into range for candidacy. The stimulator trial was awkward and inconvenient, and it meant keeping a dressing dry for a full week without a shower. About 1 in 5 people in that trial did not reach the mark, and the trial period is exactly where you find that out. In this composite, relief did come, and it was substantial but partial. The burning quieted, sleep returned. The numbness did not reverse. Large fiber loss does not undo itself, which is why the daily foot check continued. That is not a cure. That is a person who got their nights back and kept both feet. If your feet burn at night, or you have stopped feeling the floor, get a real workup before accepting a lifetime prescription. Learn more at painm.tv on the diabetes and neuropathy page. Everything I have said here is education, not medical advice, and it does not make me your physician. Individual results vary. The numbers I quoted are trial averages, not a promise about your feet. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Bring your labs and medication list and take your shoes off. If something in this changed how you understand your own pain, that was the point. Bring us your imaging, your history, and your questions. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Everything in this video is education, not medical advice. Ask for the diagnosis before you accept the procedure.